Hi, my name is Anne Marie Cox. I work with the Town of Granby Youth Service Bureau as a counselor and also as a certified prevention specialist. I want to thank you for joining me for the second in our parent prevention series. Our topic today is going to be community-based suicide prevention. So the first part of this presentation is going to focus on the information we need as members of the Granby community. One of the things I learned as I trained for my certification as a prevention specialist is that the state of the art in prevention focuses on community prevention. Not experts, not treatment providers, but everyday members of the community, because prevention is about understanding risk factors and addressing them at the source. And who has a better view of what's going on with friends, children, and neighbors than the community members they live with and interact with? We're the first line of defense in preventing many things, from drug addiction to suicide. Our education is the key to identifying those at risk and getting them help. So today, let's take a look at what we need to know about suicide in order to help prevent this from impacting our community. Today's presentation is going to be broken up into about 7 different sections. So if your time is limited, you can feel free to watch one part of it and then hit pause and come back and join us again for the remaining parts. We're going to start with, is this a problem? And I'm going to be honest, I'm going to throw a bunch of slides of statistics at you. Don't worry about remembering the specifics. It's the overall picture that's important. You may not have time to watch everything right now. Like I said, no worries. That's why we moved to a streaming format. Take the 5 minutes to watch a section, then hit pause. The next time you've got 5 more minutes, watch the next piece. So we're going to break this up into looking at what the problem is, talking about myths versus facts. We're going to look at who's at risk, what the warning signs are, how to ask the question as to whether somebody's at risk for suicide, and then how to get them help, and what are the resources that are available to people. Youth suicide. So as parents, this is the one that's the most important. It is the 3rd leading cause of death for kids ages 10 to 24. Really, we could stop right here. This is enough to justify learning about suicide prevention as a parent. The rates on suicide, these rates are on the increase. Teen suicide rates have been increasing since 2012, and the CDC reports that suicide rates among girls is at an all-time high in 2017. We're going to explore that alarming trend in our presentation on internet and social media that seems to be directly related to this increase. That'll be coming later on this year. Again, overall suicide rates in the U.S. are on the increase. And if we look at suicide rates by age, while it's the 3rd leading cause of death in young people, it's really important to understand that this is an issue of the lifespan. And when we look at where the highest rates of suicide are, they're in our elderly population. When we look at suicide rates by race, men are at the greatest risk across ethnicities, with men and Asian men leading as far as being at risk for suicide. When we look at suicide rates by state, we can see that Connecticut is actually a lucky state. Or possibly it's something besides luck that is helping us. This next slide, look familiar? Actually, it's not about suicide rates. This slide is looking at the proliferation of guns state by state. So we can see that suicide rates tend to be lower in states with stricter gun control, simply because it limits the access of a suicidal person to the most deadly means of suicide. This slide also looks at the different and most commonly used methods of suicide. So firearms are the leading cause of successful suicides, followed by suffocation, poisoning, and then other different types. This next slide just reiterates that, with firearms leading the way, followed by poisoning and suffocation. So what are the costs of suicide? This shows us that there is a very profound cost to our country based on suicide. So successful suicides cost us $50.8 billion a year. So in summary, suicide is real. It impacts all ages, and it costs us a lot of money. And Granby is sadly not immune to its impact. So next, we're going to dive into some of the myths about suicide that we need to understand if we're going to have the confidence to address the risk factors we see in our community members. Most people can be prevented from killing themselves if they're offered help and hope from the helplessness that they're feeling. Getting them the help they need might mean that they're never suicidal again. Usually, talking to a suicidal person about what they're feeling helps them feel less anxious and makes an impulsive decision less likely. Treatment for suicidal ideation does take a professional, but identifying those at risks, reaching out and helping connect them with resources is often best done by family, friends, and community members who know the person. So the myth is that only experts can prevent suicide, but the reality is that most people will respond to the help from a friend, a neighbor, and anybody who is able to reach out to them and show and say that they are concerned and that they've noticed problems. Another myth about suicide is that suicides happen without warning. It's important to understand, particularly as parents, that most teens who attempt suicide or die by suicide have communicated their distress or plans to at least one other person. These communications aren't always direct, so it's important to know some of the key warning signs of suicide so that you can identify them. But suicide usually does have warning signs. Another myth about suicide is that talking to teens about suicide might make them more likely to kill themselves. In reality, talking about suicide with teens gives them an opportunity to express their thoughts and feelings about something they may have been keeping secret. Research clearly demonstrates that there are no long-term effects of asking teens about suicide that leads to an increase in their rate of suicidality. In fact, discussion brings it to the open and allows an opportunity for intervention. Therefore, youth who come forward to caring adults following a presentation on suicide is more likely to result in providing that youth with the help that they need and identifying the ones that are already suicidal, the freedom to confide their plan to others, and then the healing can begin. So talking is usually a relief, and it provides a connection and begins to offer that first glimpse of hope. Suicidal teens overreact to life's events. And I do hear this a lot, that they're just, there's no big deal. How can they be so upset? Their problems aren't real. But we have to remember that problems may not seem like a big deal to one person, particularly an adult, but that might be causing a great deal of distress for the suicidal teen. We have to remember that perceived crises are just as concerning and predictive of suicidal behavior as actual crises. So as a parent, we may know that breaking up with that boyfriend or girlfriend is not the end of the world. That doesn't matter. That child feels like it is. Another myth is that suicide is an act of aggression, anger, or revenge. The reality is that most people who kill themselves do so because they feel that they don't belong anymore or that they're being a burden on others. They feel that their death will free their loved ones of this burden. This is particularly true in our elderly population. Many suicides occur in ways and in places that the person hopes will ease the shock and grief of those who are left behind, or how you believe that person should think, feel, or act. Another myth is that suicide is always an impulsive act. Although there are a small number of people, especially among adolescents or school kids, who are not going to communicate their intent and are going to act impulsively, that's the exception. They are most likely going to be letting their friends know, dropping hints, writing essays that their English teacher might pick up on, dealing with the concepts of death or depression. They may tell teachers, coaches, or friends. So when people say that they are suicidal, they're not crying wolf. It's really something to take seriously. So schools are in a position to try to communicate to kids that talking to your friends is fine, but if you really are a friend of this person, keeping a secret about something as serious as suicide is not in their best interest. And they need to pass that information on to teachers, the principal, counselors, family members, somebody who can help get a professional involved. So next we're going to look at who is at risk of suicide. To start, we want to define the problem. Attempted suicide is a potentially self-injurious act committed with at least some intent to die as a result of that act. Suicide is an attempt to solve a problem of intense emotional pain at the time when the person has impaired problem-solving skills. Individuals of all races, creeds, incomes, and education levels die by suicide. There is no typical suicide victim. Characteristics of suicide. It's seen as an alternative to a problem that is perceived as unsolvable by any other means. It's important for us to look at suicide from this perspective. Loneliness, isolation, really can lead people to think that they have no other choices. And they are in such a state of depression that they are not using good reality testing. And so this is an alternative way of looking at problem solving. Suicide can then be understood as less about being a wish to die than a wish to escape the intense emotional pain that is generated from whatever appears to be so insolvable in their life. And as an aside, they've done some studies on the Golden Gate Bridge. Happens to be a very common place for people who are suicidal to go to carry out their suicide plans. And so they've done some post-suicide attempt interviews with people who actually jumped off the Golden Gate Bridge and survived the fall. And 100% of the people who agreed to take part in that interview stated that the moment they jumped, their thoughts went from wanting to die to, oh my God, I don't want to die. One of the interviewees described trying to swim through the air so he would avoid crashing into one of the abutments. So it really comes down to that fact that it's not about wanting to die, it's about wanting the pain to end and being irrational in that moment when they make that decision to try to kill themselves. So we look at a suicidal person and recognize that they're often ambivalent. What this means is the person is feeling two things at the same time. There's a part of that person that wants to die and a part that wants to live, and both those parts need to be acknowledged. The part that wants to die tends to be the part that wants to die because that is perceived as the only way to end the pain. The part that wants to live is desperately hoping or looking for something that will give them hope that there is another alternative, that there's a way to live without that pain. Suicide solution has an irrational component, as we can all figure out. People who are suicidal are often unaware of the consequences of suicide that are obvious to the rest of the world. For example, they're usually not thinking about the impact of their death on others, or they hold this bizarre perception that they're somehow going to still be a part of the world after they kill themselves, whether that's feeling like they're going to be reincarnated or they're somehow going to still be present to see how others react to their death. And this is very common in adolescence when they think about how people are, they want to see how sad people will be or who will miss them once they die. So again, we need to understand that suicide is irrational. That is why getting help is so important, because most people with help can find a more rational solution to the problems they're experiencing. Once they begin to think more clearly, suicide no longer makes sense as the best option to dealing with the pain that they're experiencing. So suicide is a form of communication. For people who are suicidal, normal communication has broken down. And the suicide attempt may be the person's way of sending a message or reacting to the isolation they feel because their communication skills have become so ineffective. So many suicidal people feel so incredibly alone and isolated, even if that's not actually the case. So when we look at death by suicide and compare it to psychiatric diagnosis, the evidence is pretty clear. We've got research done over 50 years from a number of different countries, and we know that 90% of people who die by suicide are suffering from one or more psychiatric disorders, either major depressive disorder, bipolar disorder, alcohol or substance abuse, schizophrenia, or other personality disorders. So when we begin this next chapter in looking at risk factors, these are important things to look for. Start with depression, which is a major risk factor for suicide. 4 out of 10 children and adolescents will have a second episode of depression within 2 years of having the first one. Depressed adolescents are at an increased risk for substance abuse and pregnancy, and over half of depressed youth will attempt suicide, and at least 7% will ultimately die as a result. So early identification and treatment of depression can really save lives. So what are the signs of depression? They can vary from person to person, and one single sign isn't going to be enough to identify somebody as definitely being depressed, but we're going to look for groupings of these. And again, these are red flags, and if you see one red flag, that might be a cause of concern. You see 5 or 6 of them, it's definitely something you might want to act on. So we look at these: the loss of interest in normal daily activities, feeling sad or down, feelings of hopelessness, crying spells for no apparent reason, problems sleeping, trouble focusing or concentrating, difficulty making decisions, unintentional weight gain or weight loss, irritability, restlessness, being easily annoyed, feeling tired or weak, feeling worthless, feeling a loss of interest in sex or dating, thoughts of suicide or suicidal behavior, obviously, and unexplained physical problems such as back pain, headaches, stomach aches. So what we want to look at are behavioral changes that last for 2 weeks or longer over an extended period of time, and that moves us into a real red flag category. When we look specifically for signs of depression in youth, all of those others apply, but we also look to oversensitivity to criticism. We can also see in teenagers high risk-taking activities, hyperactivity, real low self-esteem, indecision, a withdrawal or inactivity. So when we talk about withdrawal, somebody who's been really avidly into sports suddenly not wanting to be on the team anymore, or withdrawing from social groups. Somatic symptoms and complaints. So that again, we talk about the headaches, the stomach aches, the just feeling unwell. It's not uncommon for depressed adolescents and typically boys to be aggressive and hostile. Again, the sleeping disturbances and eating disorders kind of cross ages. When we look at other risk factors, again, we talked about mental disorders, depression, particularly the mood disorders, schizophrenia, anxiety disorders, and other personality disorders. Alcohol or other substance use disorders are a concern. Hopelessness, impulsivity or aggressive tendencies, a history of trauma or abuse, some major physical illness, a previous suicide attempt, or a family history of suicide attempt. All of these risk factors would be something to pay attention to in somebody who appears to be unhappy. We can look at the environmental risk factors. So someone who's experienced a loss. So for an adult, it could be the loss of jobs, financial loss, or having to drop out of school. For a teenager or a child, that loss might be a family loss, a parent losing a job, a parent experiencing a financial loss, being homeless, the loss of a relation or a social loss. Easy access to lethal means, which means access to guns as the most lethal means of suicide, is an environmental risk factor. And local clusters of suicide that can have a contagious effect. So again, if somebody is already depressed and is already having some suicidal ideation, and there are a well-publicized cluster of other suicides in a neighboring town or community, that can make that person, particularly that child, feel like, oh, this is a reasonable way for me to deal with the pain that I am experiencing. Some other things we look for are a lack of social support and a sense of isolation. And if somebody's coming from an environment where there's a stigma associated with help-seeking behavior, maybe there's a family rule that says that counseling is for people who are weak, or that therapy is not helpful, or we don't talk to people outside of our family about our problems. Maybe they have barriers to accessing health care, especially mental health care and substance abuse treatment, maybe a lack of insurance or an inability to access those treatments. Certain cultural and religious beliefs, for example, the belief that suicide is a noble resolution of a personal dilemma. And exposure to, and including through the media, and influence of others who have died by suicide. And that one, I'm going to talk about it, I believe, a little bit later, but one of the reasons why many people in the mental health world were concerned about the TV show that was so popular calling 13 Reasons was because it did, in a way, glorify suicide, and kids were very interested in that show and watched it avidly. And that was one of the reasons why many mental health professionals were cautious about having parents watch the show with their children and at least talk to their children about the thoughts that they had related to that show. Some youth-specific risk factors. A lot of these are common sense. Kids who are experiencing the divorce or separation of parents. Children who are harassed by peers. Bullying that has been ongoing and relentless has been a frequent cause of suicide in our middle school and high school age. Having a sexual identity crisis. Gay, lesbian, bisexual, and transgender youth are at a much greater risk of suicide than their straight peers. Easy access to lethal means, especially guns, increases the chance of a successful suicide. Experiencing a school crisis, either disciplinary or academic, failing a grade or test or a class. And some of this, and it's not always failing, what somebody outside looking in might not see as failure, but a really academically motivated, high-achieving student might see a B on an important test as a failure. A genetic predisposition. Definitely it can be family patterns in depression, feelings of isolation or being cut off from others, ineffective coping mechanisms, inadequate problem-solving skills, cultural or religious beliefs, and exposure to suicide or a family history of suicide. When we talk about LGBT youth being more likely to commit suicide, it really is important to understand that it has less to do about the sexual orientation and much more to do with the fact that LGBTQ youth are far more likely to experience rejection by family and peers. They are more likely to be kicked out of their homes and become homeless. It's the lack of acceptance and support that leads to that depression and the increased risk of suicide. When we look at LGBT youth who experience acceptance within their families and within their communities, we see that that acceptance decreases the rate of suicide significantly. For example, when the ban on transgendered soldiers was announced, the calls to suicide hotlines increased dramatically. And then going back a couple of years ago, when same-sex marriage became legal, there was a significant drop in calls to suicide hotlines. So it is the acceptance and support more than the sexual orientation itself that seems to lead to that increased risk of suicide in that particular population. Some other youth-specific risk factors influence through personal contact or media representation of significant people who die by suicide. So when a rock star ODs or things like that, that can cause an increase in suicidal ideation and action. Loss or separation, exposure to violence, family crisis, whether it's abuse, domestic violence, parent-child conflict. Again, barriers to receiving health treatment or stigma associated with that, experiences of disappointment or rejection, feelings of stress brought about by perceived achievement needs. So when we talk about that, it's important to understand that, as I said before, it's not only in kids who are failing, but kids who have set a bar so high that even what other people would consider to be very successful academic career, they feel like they're not achieving what they need to do, that they have somehow feel they must have straight A's and, exceptional SAT scores and, that they can see what others would perceive as a very small, loss. A few points off of what they thought their SAT scores could be can take on huge proportions for them. An unwanted pregnancy or an abortion, HIV or another STD, and serious injury that can change life course, suffering a TBI, or a sports injury that changes a life plan on being able to play soccer or something like that. And obviously a severe or physical terminal illness or mental illness or a substance abuse disorder is something that can influence and increase a child's risk. So those are the risk factors. Not everybody who experiences those risk factors is going to be suicidal. So what are some of the warning signs? If someone we know is going through some of these things, we know there's risk factors in their lives, what do we look for to see whether that person is feeling and coping successfully, as many people do with these life traumas, or if they are having trouble and are tending towards feeling suicidal. So some of the warning signs are when we hear that person describing themselves as feeling trapped, like they're saying things that make them sound like they feel like there's no way out. If we notice an increase in alcohol or drug use. If we see them withdrawing from friends, family, or society. If they're expressing feeling anxious, if they act agitated, they're unable to sleep, or they're sleeping all the time. And if they're experiencing dramatic mood swings, and if they state that they see no reason for living or have no purpose in life, these can be warning signs. But it's important also to look at all of these and as a pattern. Will every suicidal person show all of these warning signs and the other ones we're going to talk about? No. Will some people who are not suicidal experience some of these warning signs? Absolutely. As a parent of a teenager, if experiencing dramatic mood swings was a single, this means the child is suicidal, every teenager, including the two of them that live with me, would be suicidal. They're not. So you have to look at the whole pattern and the picture that's presented. So again, some other warning signs. Obviously, it makes sense. If they're threatening suicide, that's a big red flag that we always take seriously. If they discuss or you find that they've written down or are talking about a suicidal plan, if they're talking about and know about a method and access, that's a big red flag. Making final arrangements. This is a red flag as well. So what does that mean? It can take on different forms with different people. Sometimes making final arrangements is giving away prized possessions. Oh, if anything ever happened to me, I want you to take care of my dog. Would you take care of, of Skip if something happened to me? It can be writing letters or notes that sort of tidy things up and say, I'd really like this and this and this to happen in my room, and if anything happened, I'd like you to give this piece of, this to my brother, those sorts of things. With adults, it can be, taking care of financial things and writing wills, so it changes depending on the age of the person and where they are in life. Sudden changes in physical habits and appearance can be a red flag. Preoccupation with death and suicide themes is often a red flag, and that's one that's fairly commonly seen in teenagers. And actually, give credit over the years of working as a school psychologist of the number of English teachers who made really wonderful referrals for counseling to kids because they picked up in the things that the kids were writing, this preoccupation with death and suicide themes. It can also be seen in the music that they start listening to. Might be a change to much more darkly themed music, the poetry that they write, the art they may be producing. And art teachers are also another common referral source because they identify those themes in the creativity of their students. You might see an increased inability to concentrate or think clearly. A loss of interest in what was usually or previously pleasurable activities. And again, the symptoms of depression. And changes in their use of alcohol or drugs, sense of hopelessness, rage, anger, revenge seeking. These things can be signs. So we have reckless behavior or activities. This is really also common with adolescent boys. Sometimes they mask suicidal behaviors with driving really fast or doing things that really push that edge to really dangerous activities. Again, that feeling of trapped. We've talked about anxiety and agitation and the sleep difficulties. Dramatic changes in mood. Again, teenagers tend to be dramatic, but we're looking for over a prolonged period of time and looking for maybe a constellation of these symptoms. Sudden or recent purchase of a weapon or increased interest in a family-owned weapon. Talking about that they have no reason for living, no sense of purpose in life, a sense of being a burden, a profound sense of loneliness, attention and isolation, and a sense of fearlessness, and that fearlessness can be kind of tied into that high risk-taking behavior. So, you've identified that this person has risk factors in their life. You looked to see if there are warning signs, and there are. What is the next step? And that is asking the question. You paid attention, and you see a friend, and you notice the warning signs. So next step, which is usually the hardest one, is the suicidal inquiry. I'm not exactly sure why this is always so hard. Honestly, I think maybe it's because we're afraid of the answer. So we know that there's something wrong, and we're worried about this person. It makes sense that we want to find out for sure what's going on. But I do think that sometimes what holds us back is that thought of, oh my gosh, what are we supposed to do if they say yes? If I ask, are you thinking about killing yourself? Are you considering suicide? And you say yes, oh my God, does that make me responsible for fixing things? That huge sense of responsibility and fear, I think sometimes holds us back. And so it's really important from a community prevention standpoint for you and me to really understand that the answer is that no. If they say yes, they're suicidal, it is not our job to fix it. Our job as community members is to be educated about the risk factors, educated about the warning signs, be brave enough to ask the question, and then simply connect that person with the experts who can help fix the problem. By asking the question, yes, we have that responsibility to act on the answer. If they say yes, We want to connect them with help, but that is where our responsibility ends. So people struggle, but we need to be brave. We need to get over our discomfort with the question. And, you know, sometimes, like I said, we're afraid what the answer is going to be yes, but we want to get over that. You know, and again, which I say to kids all the time, you're afraid to ask because you don't want your friend to be mad at you. But which is better, a mad friend or a dead friend? So being brave and asking the question is really important. So how do we ask? So we don't want to hesitate to raise the subject. If you've seen warning signs and you know that there's risk factors there, be direct, but don't be confrontational. Engage them. So before you jump into these suggestions here, let's think about, where are you going to do this? You probably want to time this, if you have the luxury of doing it in a place that's a little bit private, because you're asking about some things that are pretty personal. So for kids in the lunchroom, or for a coach on the sideline at practice, probably not the best time. Do it when you can pull the person aside, where you've got a little bit of privacy, and also where you have a little bit of time. Don't start this conversation if you know in 10 minutes you absolutely have to be somewhere else. You want to be able to know that you have the time to deal with whatever the answer is going to be, and that might take some time. So, some ways to be direct and non-confrontational. Simply ask, you know, are you thinking about suicide? Now, for me as a counselor, you know, I'll give you some examples of how I would do this. I usually start off with what I've noticed about the person. You know, it's like, you know, Jamie, I've noticed that you seem really sad, and I know from what we've talked about or from what you've said that there's a lot of stuff going on at home, and you've got some real, you know, worries. And I'm concerned about how you're dealing with that, and I wanted to know, you know, have you been thinking about suicide? You know, so something that rationally kind of leads into it. And then you can ask, you know, what thoughts or plans do you have? Part of that is trying to figure out how serious this is. Many teenagers have thought about suicide once or twice, you know, oh, I should just kill myself. But that is different than really having thought in detail about wanting to die and having actual plans about what they're going to do. So you might ask them about that. Well, you know, have you thought about this? How often do you feel this way? Are you thinking about harming yourself or ending your life, is another way of phrasing it. How long have you been thinking about suicide? Have you thought about how you're going to do it? Do you have a plan? You know, and do you have access to a gun at home? That's an important thing to understand, because that directly impacts how at risk that person is to a successful suicide. Do you really want to die, or do you want the pain to go away? These are all some things that you can ask. And typically, people who are feeling suicidal, and we talked about how isolation really plays into that. In 25 years of counseling students, I have never had a suicidal student get angry that I asked them about that. I've never had a non-suicidal student get angry about that. They've been like, no, Missy, I'm fine. You know, I'm really, you know, stressed out about this, but no worries there. They don't get mad, because you know what? People don't ask if they don't care. So that fear that we have that somebody's going to be mad at us really doesn't, at least in my experience, play out. Most people are just like, hey, it's kind of nice that you're worrying about me. So you've asked the question. The person has said yes. And, you know, there may be yes, and I have a plan. Yes, no, I'm not really, don't have a plan, and I don't plan on doing anything right now. But they've given you enough to know that suicide is something that is in their mind. So next is the intervention. What do we do with this? The first thing is that you show you care, all right? There's lots of things and secrets that we might keep for a friend, like, and again, when we talk to kids, you know, and teenagers about whether they share, how do they intervene with a child that, or a friend who is suicidal. Show you care. The way we show we care is we express that we're worried about them, we want them to live, and we want them to get help. And that they need help. There are many, many things that we can choose to keep secret with our friends and our family. We might choose to not share with somebody who they have a crush on, or that they failed a test, or even something that somebody we know did that they shouldn't have done. And those are things you can choose to do based on your friendship and values. But keeping a secret about someone who's feeling suicidal is never a good choice. We need to connect them to with the resources to help them. So as a community member, your role is to see the red flags, ask about them, and then connect that suicidal person to the resources that can help them. It's not your job to be the counselor or the therapist. It's only your job to help hold that person's hand until you can connect them to that professional. So again, showing you care. Take all talk of suicide seriously. If you're concerned that someone may take their life, trust your judgment. You listen carefully, you reflect what you hear, and you use appropriate language for the age of the person that's involved. Focus on the feelings that they shared, not your judgment about the validity of why they feel that way. So for example, say, oh, you sound so lonely, so isolated, and you seem to feel so disconnected from everybody. And instead of trying to reassure them that, oh, you've got more friends than you think, or you're really not so alone, you can say, I don't want you to feel this way, and I want you to feel better. And I really believe you can feel better. But validate the feelings that they're having. Be genuine. Let the person know that you really care. You can talk about your feelings. I mean, you can ask them about his or hers. Don't be afraid to get it wrong. Most people are going to be simply so glad that you noticed that they were sad and are reassured that, you know, they've made that human connection. So they're going to want to, you know, reassure you that they're okay. And if they're not, if they are depressed and feeling suicidal, then there's some additional questions you can ask as you move towards connecting them with help. So as I talk about that, a couple of things to ask. When you ask that question, you're depressed, and they share that they're depressed, you ask them about being suicidal or not. One thing to think about is there really, I said, there's no real wrong way, except there actually is one wrong way to ask about being suicidal. And it's when we can ask in a way that makes it very clear that we really don't want them to say yes. And that's when we preface a question about being suicidal with, you're not thinking of killing yourself, are you? You're not suicidal, are you? You're not going to hurt yourself, are you? That just really sends a pretty strong message that please say no, please say no, please say no. So just that would be the one caveat, that when it comes to asking that question, don't preface it with the negative. Don't say you're not. Just say, are you? Or I'm worried. People in your experience and in your situation sometimes feel that way. I wanted to know if you've been feeling that way. Keep it open-ended so that it's letting them know that you're okay with whatever it is that they're going to say. So now, getting help. What do we do when we've identified that the person that we have been talking to is in fact suicidal? Well, one of the first things you can ask is, are they in counseling? So as we know, people who are depressed, who have a mental illness, are the most likely to be suicidal. It is very possible that they're working with somebody. And that's important to know, because if they have a therapist or a doctor, that is probably going to be your first phone call. So ask, are you seeing him or her? If they say, yes, I have a therapist, are you seeing him? You might find that, well, no, I haven't seen him in about 3 months, or I haven't seen him in the last 6 months. That's a really great follow-up. Well, then what do you think about me? Let's call him. Let's call her and see if we can get you an appointment, or you can talk to her on the phone. Ask if they're taking medications that have been prescribed. It may be that they had an antidepressant and they have stopped taking it because of insurance issues or something like that. Good information for you to have. And as I said, we ask this because if they already have a connection with a counselor, that's a really good place to start with reaching out and getting them the help that they need. One of the things you want to do, particularly if the person has expressed that they are in fact suicidal, they do have a plan, or they have thought about a plan. If you know that there's access to a weapon at home, you don't want to leave that person alone unless there's absolutely no choice. And the no choice, it could be, you know, depending on the age of the person you're dealing with, they could literally get up and leave and get in a car and drive away. If that doesn't happen, stay with them. And then know your referral sources. You're going to reassure the person that you believe with all of your heart that things can can get better, and you're going to encourage that person to participate in the helping process by saying things like, I know how sad you are, I know how unhappy you are, I really believe that if you get some help and support that you can feel better, things will feel better, you will get better. I really want you to come with me while we call 211, or we talked to your mom, or we go down and talk to the guidance counselor at school. And what we want to do is outline a safety plan with them. So what that safety plan means is, you know what, we're going to go down to and call 211, and I'm going to stay with you until we figure out what the plan is. Or let's call your mom and have your mom come and pick you up. And then in talking with a parent, the parent's safety plan may be that the parent is going to stay with that child until they've made arrangements to get her or him to the therapist. But your job as that initial person who got the yes to the suicide is to connect them with some safe person. So that might be, as I said, a call to 211 in Connecticut. That's one of our go-to resources, suicide hotline, where they will talk to the person online, they'll do some evaluation, and they'll make those next connections, whether it is calling an ambulance to get them taken to the hospital for a suicide evaluation, or being on the line with them while there's phone calls made to a parent or a husband or a wife, someone who can then come and be with that person and assure their safety until they're able to get in to see a therapist or a doctor, and they can start treatment. So your role can be considered done once you reach out to professional helpers and have connected that person with that support. When we look at our local resources, Granby specific, if they already have a therapist, as I said, that's a good call to make. I also mentioned in Connecticut, we can call 211 to get help for a suicidal person. We can also get others involved in support. Sometimes it might be, again, if you're dealing with a youth, the first phone call is really going to be to that if they are not out of control and you need to be calling an ambulance to have them come and be picked up and taken to the hospital, you're going to be calling parents and letting moms or dads or grandparents know that this is information that was shared with you and that you're concerned and you're here with their child, and you're going to wait until that parent can come and get the child. We also have schools. So obviously if you're getting this information and it's you're a teacher, you're a coach, you're somebody who's working with students during the school day, the school personnel are fabulous resources. You've got guidance counselors and school psychologists who can be that person that you pass the baton off to. If parents come, and for parents who might be identifying a suicidal child, these are also really excellent resources to call and to get help connecting to other resources. And obviously, I work with the Youth Service Bureau in town. We are also a resource. We are not necessarily a crisis intervention organization, but we can absolutely work with families to help evaluate the risks and connect families with counselors and therapists for their child. And then we can look at expanding a network of safety and support. So wives, husbands, pastors, ministers, priests, this network of safety and support can be really helpful as somebody goes through treatment and reaching out to deal with the depression that's led them to feel the way they do. And as I said before, if a youth is involved, obviously parents have to be informed. Then we look at some national resources, and again, this is a lot of information, and it will probably scroll through a couple of times for you, but when we look at them, we have places like the National Suicide Prevention Lifeline and the American Association of Suicidology. I actually got some of the slides for this presentation from them. The Suicide Prevention Action Network, the Suicide Prevention Network in Spanish, the American Foundation for Suicide Prevention, the Florida Suicide Prevention Implementation Project, which has been cited nationally as a really good one, and a number of others as we kind of go through. All right, thank you for joining me and spending time going over that. I know it was a lot of information, and I'm hoping you get the broad concepts of community-based prevention, which is really we are going to be the first line. We're going to be the ones who are the most likely to notice a problem with someone that we care about or interact with. And if we have the confidence that we can identify some of those risk factors, by identifying them, that empowers us to know that we want to ask the question. By asking the question, we get it out there in the open, and then our job is simply to connect them with the resources that are available within our community. And so that's a really empowering thing. And if you want more detailed information, all you have to do is give the Youth Service Bureau a phone call, 860-844-5355, and I will send you all of the lists of the risk factors, the myths, any of the information that you want so that you can have it at home to review. So this has been a great presentation geared specific, well, I don't know if it's great. I hope you thought it was great. This has been a presentation geared towards adults. One of the things that I'm working with my T2T, which is a teen-to-teen peer education program, is that they are developing a presentation that is geared towards tweens. So that's your 11, 12 to 13-year-old age group. This is a really unique population because what we know about tweens is that they are the least likely age group to share information about a suicidal friend with an adult. They keep secrets, and we'll go into the whys of that. But what these kids in my T2T program, their high school students, are doing is putting together another program that will be streamed just like this, that is geared specifically for parents to watch with their tween age kids to address that, to look at some of the unique factors, including internet and Instagram and suicidal statements that are made via social media, and how to encourage our tween age kids to share that information with caring adults so that people can get the help that they need. So again, I thank you for spending time with me today. I hope that if you know somebody who has a tween child, you'll let them know about the upcoming tween presentation that hopefully by the end of this month will be up and running. And later on, there'll be even more topics that we'll be presenting. So stay tuned. Thank you.